I'll just tell you my take on these drug-eluting technologies, stents and balloons, and certainly they're more expensive, but the question that I'm going to try to answer is it worth it? You can go forward. So, I want to go back to that slide, actually. I'm sad to report I have nothing to disclose. If anybody... Okay. So just from a 30,000 foot view, the generally things I'm going to talk about today are introduction to sort of femoral popliteal vascular disease, and not so much the anatomy of it or the physiology and why it happens, but really how we're treating it today and what the future holds for that. Next, I'm going to talk a little bit about some data to support or not be in support of using drug-eluting technologies to treat this problem, and then that'll sort of milk my way into a cost-benefit analysis of doing this. Go ahead. So the first is that slide I promised you about trends. And so this is a paper that was written by a friend of mine, Phil Goodney, who works in Dartmouth. And he basically wanted to sort of understand the way American vascular surgeons or vascular interventionalists are treating lower extremity vascular disease. And so he took all the data from the Medicare database for a decade. So it's a whole lot of patients. I don't even have to remember how many it is. But he looked at a few things. What is the rate of sort of traditional open lower extremity surgery for these patients? Again, they're all patients that have vascular disease that is hemodynamically significant below the hips. And so what is the risk, what is the rate of open lower extremity bypass surgery, the femoral popliteal bypass or some variant of that? What is the rate of percutaneous or endovascular interventions with balloons or stents or what have you? And what's the rate of amputations during that same time period? So you're going to hit that for me? And so what he found is during this decade, from 96 to 2006, the rate of open lower extremity surgery actually decreased by almost half, which was kind of a surprising thing to find because, you know, this is the way that at this time we're mostly thinking about treating these problems. And go ahead. And at that same time, these endovascular interventions through the skin, no incisions, minimally invasive, actually increased by 400%. And so maybe the thought is the interventionalists are getting a little bit more lazy. They don't want to do the 6-hour bypass or the 4-hour bypass or whatever it is, and they're going to go in, do an angioplasty, get out, and then just let the patient fall where they may. But the next, hit it for me, during that same time period, the risk of losing a part of your leg decreased by 30%. So the patients are actually doing better. Go ahead. So we know that these endovascular interventions are better for the patient. So these stents, balloons, minimally invasive, we all want minimally invasive surgery. Certainly I'd prefer to have that if I was the patient. So if minimally invasive is better, what's the best? Is it balloons? Is it stents? Is it something else? One of the reasons that we use stents now is, or at least up until now, is for patients that we've tried other things on and it doesn't go quite as well as we'd like. If you'll hit that next slide for me, Paul. And so this is something that almost every vascular interventionalist has seen probably multiple times a day. This is a segment of the femoral artery just above the knee, and there's either a total occlusion or a near total occlusion sort of right in the middle of the screen there. And so the surgeon was lucky enough to get a wire past that, and then he blows it up with a balloon and hit that next. And the balloon, I can assure you, was the exact same diameter as the artery, and you can see that this is the result that was given. And it doesn't look very pretty. It's still very small. It's better than when we started, but there's what I would still consider a flow-limiting lesion. And the reason I can say that it's flow-limiting right there is because you see all those other twig vessels coming down. Those are collateral blood vessels that really shouldn't be there, at least not in that number, and they shouldn't get down the leg faster than the main drag of blood flow. So the next slide. So a stent was put in, and this is what it looks like. So these stents make it look better on the pictures, but from a hemodynamic standpoint, for the blood pressure and the blood flow that's getting down to the leg, these are better. Go ahead. Here's another thing that we use these for. This is a flow-limiting dissection. I don't know if you can see the dissection up there at like 21 to 23, and it actually carries all the way down to the bottom of where that column of blood flow is, and the blood flow stops, and so that's obviously very abnormal. And so if you get this while you're doing a procedure, the bailout is to put a stent in this place, and you get a prettier picture again. Go ahead. And so there's lots of benefits to using these stents. It lets you be a little bit more aggressive when you treat the patients, but the one thing that we didn't know is whether using these stents improves limb salvage, and there's a couple of reasons for that. All these studies that are done regarding lower extremity interventions, especially with stents, primarily are focusing on whether the lesion that gets treated stays open. There's not a lot of mention made about what happens to the patient's leg down the road, and do they keep their toes, do they keep their leg? All that really matters is if the lesion stays open. As you can imagine, if your stenosis stays open but you lose your leg, not so great. The other thing is a lot of these procedures are done these days for what we call for patients that have claudication, or basically pain when they walk, but they're not really at risk of losing a leg, so it's kind of hard to prove that you saved someone's leg if they were never really at risk for losing it. Go ahead. There's disadvantages to using stents, certainly. One of the things that's been a primary disadvantage in years past, not so much today, is that putting a stent in required a larger hole in the artery, a larger access site. A larger hole leads to more risk of bleeding, more risk of postoperative complications. As I said, sort of as the technology for the delivery of these devices improves, that's becoming less of a problem, and the delivery systems are about the same size now. The big knock on stents is that they cost a lot more than just using a balloon. And if you'll hit the slide for me, I would say that this is probably the most expensive complication of a stent. So there's a stent that's been put in, you'll outline it for us there. And it obviously doesn't look pretty like those last pictures that I showed you. It's a tiny little lumina flow, not enough blood's getting down to this woman's leg. And this is a hard thing to treat, if you'll hit that slide for me. These are things that are very inflamed. There's a process called intimal hyperplasia that is very different to treat than just sort of treating run-of-the-mill hardening of the arteries from smoking or from eating too many hamburgers. So it's a bad problem to treat. A lot of patients get it in a significant manner that causes them symptoms. And it's not something that we can treat with just balloons or repeat stenting. It usually requires more expensive modalities like the atherectomy devices that were talked about earlier, or lasers or other fancy things that you can see on an Austin Powers movie. So if you hit next. So there's a lot more cost with treating the complications of these stents. Go ahead. And so this is another set of data that's taken from Medicare, and what this is trying to show you is what it costs to treat a lesion the first time, what it costs to treat a lesion, and these are all lesions in the thigh, a lesion the second time, and which one's more expensive. So you can see that if you treat something the first time with a balloon and with a stent, it costs you about $7,000 to do it. If that goes down, and then you bring the same patient back, because these things are harder to treat and you're using more expensive devices, and you're probably going to bring them back multiple times to do it, to treat the reintervention, exclusive of what you've already paid to take care of them, it's about another $17,000. So you hit the slide for me. So it's about 240% costs added when these problems recur. Go ahead. And so this is some data just as a way to kind of talk about drug-eluting technology. This is some data on the Zilver PTX study for femoral popliteal artery disease. This was presented at a meeting in Las Vegas about 2 years ago by Dr. Ansel. Go ahead. And so the Zilver PTX is a femoral popliteal stent. It was talked about a little bit before. It's basically a bare metal stent that we've been using for a while, but now it's got drug-eluting technology, and paclitaxel is the drug, one of these chemotherapy agents. This is a stent that's available all over the world, but most importantly here. Go ahead. And so this is the design of the study. They had about 480 patients that were enrolled, and they were randomized to either get a balloon and no stent, or one of these sort of what I would call the Maserati of stent, the Zilver PTX. Now, it's not exactly at first view, it's not a really fair comparison. There's something in between there. And really, to prove that a Zilver PTX is better, you probably need to compare it to a stent, but we'll get there, just bear with me. Luckily, or unluckily, depending on who you are, of those 238 patients who were randomized to just get a balloon treatment to start, about half of them failed immediately. And so of those failed patients, those 120 on the left, if you'll hit the slide for me, they were randomized secondarily to either get a bare metal stent or a drug-coating stent. And so I think that's probably the most important part of what this study showed. It's these people who failed sort of our standard real-world treatment, and now what do we do with them? Keep going for me. And so this is all of the patients, whether they were randomized to stents or balloons, whatever. This is the entire cohort of patients, and you can see that there's not a lot of difference between them. They were the same amount of males. They were the same age. They weighed the same. They had the same amount of diabetes. Hit the slides, with the exception of the patients who got the Zilver PTX had a little bit more incidence of hypertension. There's really no difference in the way these patients looked before any treatment was done, and that hypertension is probably not clinically significant. Go ahead. This is data specifically about the lesions that are being treated. How long are they? A longer lesion is harder to treat. How calcified is it? What percentage of blockage is it? And again, there's not a lot of difference here except for the very last box, if you can hit that for me. The patients who got the Zilver PTX had a little bit more calcium in their lesions. But overall, I would argue that the lesions here that are being treated are about the same. So the patient should do the same, whichever arm they're in, if the treatments are equivalent, which they're not. Go ahead. So this is 4 years out data. This is data that shows everybody who got the drug-coated stent. And that's a drug-coated stent either randomized from the very beginning or one of those people who failed angioplasty who then got a drug-coated stent. And that's compared to people who got a balloon angioplasty and did well with that, or who got a balloon angioplasty and failed and then got a bare metal stent. So it's sort of the end of the treatment lines for both of them, everyone who got a drug-coated stent versus everyone who didn't. And at 4 years, this is basically freedom from having to have a second operation. And there's a significant difference here. It's a 45% reduction in having to have a second operation, presumably just based on having the drug on your stent. Go ahead. And this is the same groups of patients. This time it's measuring primary patency, meaning the stent has stayed open and you haven't had to do anything to keep it open. Again, the results are in favor of having the drug-coated stent. Go ahead. And this is I think this is the most important slide on the whole thing. This is the patients who failed the balloon angioplasty, who then were randomized to get a bare metal stent, or who were randomized to get a drug-coated stent or a drug-eluting stent. And in this case, there was a significant difference, a 40% difference in the number of patients that went on to require a second operation. So if you have a drug-coating stent, you have a 25% chance, which sounds high, but you have a 25% chance of needing another operation to keep that artery open. If you got a bare metal stent, you have about a 43% chance of needing another operation to keep that open. And that becomes important when you think about those numbers we talked about of how much does it cost to do a second operation. Go forward. And so the results from this show that having the drug-eluting technology lowers the need for reoperations for those lesions. It's improved patency compared to balloons, and it's improved patency compared to bare metal stents. Go ahead. And so we're going to take all the stuff we talked about now and sort of create a not real world, but simulating real world scenario. So let's imagine we have two hospitals across the street from each other, and on the west side of the street we've got patients who are only going to get bare metal stents, and on the east side of the street we've got patients who are only going to get the drug-eluting stent. So this is one of our assumptions. We're going to talk about some assumptions here. So go ahead. So the first assumption is that a bare metal stent costs about $1,100. That's not crazy, but that's about right. We know from our slide of the Medicare data a while ago that the actual procedure itself costs about $5,100 to do this operation. Go ahead. Now, this is a gross exaggeration, but just for the sake of trying to make it fair for the bare metal stent, I'm going to tell you that the Zilver PTX is going to cost twice as much as a bare metal stent, so another $1,100. And so the cost for the procedure, I took the $5,182 from the regular Medicare data and added another $1,100 to it. Because otherwise, the procedure is done the exact same way and it should take the exact same supplies, so the difference should be the difference in the stent. Go ahead. We're also going to assume that the Medicare number that we got from before, that re-intervention costs $17,000. Seems fair. Go ahead. We're also going to assume that what happens in our two hospitals on the east and west side of the street exactly mirrors what happens in the Zilver PTX trial. I can't say that that's going to be the case, but it's probably not too far off. And so we're going to assume 43% of the bare metal stents are going to fail, and a quarter of the Zilver PTX stents are going to fail. Go ahead. And we're also going to assume that we're not going to spend any additional amount of money surveilling the patients, getting ultrasounds, getting CAT scans, or whatever. Whatever patients on one side of the street get, the patients on the other side of the street are also going to get. Go ahead. And so the numbers come out like this. I mean, I'm sure you can see where we're going here. If you get a bare metal stent, if you take all 100 patients that had an operation, the sum total for those 100 operations is going to be about $500,000. The Zilver PTX patients, it's going to be more expensive because the technology is more expensive. And so the Zilver PTX starts out behind the 8 ball. It's $110,000 more. Next one. But we've got those failures. There's 43 failures in the bare metal group and 25 failures in the Zilver PTX. Go ahead. And so if you take 43 failures and say that it's going to cost $17,000 for each of those 43, then reinterventions in the bare metal stent is going to cost you about $750,000 versus less than $500,000 for the reintervention group for a total cost of about $1.2 and $1.0 million. So for 100 patients, a hospital can save about $200,000 over the life of that patient, or at least until that patient comes to either loss of limb or loss of life. And so that's about $2,000 per patient, whether or not they had a failure. And there's some of the assumptions here actually probably make these numbers even more disparate, because well, I'll get to the next slide. Go ahead. So we know that it's not really true that the cost for treating two different patients in two different parts of the world are the same. I mean, I'm sure the cost for treating a patient is different across the street. The payer mix is important. You know, we're all right now, for the most part, in a fee-for-service model where the more operations that you do for a patient, the more times you can bill that patient's insurance company and the better you do. But I don't think that you can make an argument that bringing a patient back over and over and over again for repeated interventions is good for the patient. Not to mention the opportunity cost. If I've got patient A and I'm treating him on Tuesday and I'm treating him the next Wednesday and the next Thursday, that's 2 operative slots that I don't have to treat someone else. So it's bad for that patient, but it's also bad for the whole system because other patients can't get in to have an operation because I'm still treating patient A. The thing I was going to mention on the last slide is the difference in reintervention cost is probably very different, and it's probably a lot more expensive for the bare metal stents, but this is all just conjecture or anecdotal data at this point, because when those long stents that are bare metal start to reocclude, you get the picture that I showed you where there's a very thin column of blood going down this long stent that takes a laser or an atherectomy or something else to treat. What we've seen with the Zilver PTX is when those start to fail, the stent itself doesn't fail. You get a regular old run-of-the-mill atherosclerosis, too many McDonald's hamburgers, lesions above and below the stent, and you can treat those with a balloon. So it's actually a lot cheaper to treat a secondary intervention for a patient who's had a drug-coated stent than it is to treat a patient for a secondary intervention for a bare metal stent. And so those numbers are probably even more different. Go ahead. And so, you know, there's still work to be done. We don't really know which patients are the best patients to get just an angioplasty, because I can assure you that there are a lot of patients out there that is the best for. And we need to identify who's the best to get a drug-coated stent or a drug-eluting balloon. You know, if you bring a patient to me who's 95 years old, who is expected to live another 2 years, am I going to put a Zilver PTX stent for twice the cost in them? Sorry, but I'm not. I'm not going to do it, and you probably don't want me to, right? It's not the right thing from a cost-effectiveness standpoint to treat that patient in that way, because you don't need the 10 years of longevity that you might get with a drug-coated technology. And there's also a group of patients who aren't fit for this at all, and they need to go straight to a bypass. And so the next step is to figure out who are those patients that go into each group. I think that's it. Yes, I'm done.